Okay, we'll go ahead and get started.
Yeah. Okay, Melanie, why don't you call this meeting to order?
Okay, so thank you everyone for joining the meeting this afternoon. I'm Melanie Cavalier, the Chief of Innovative Care Delivery at the Maryland Healthcare Commission. I'd like to remind everyone the meeting's being recorded. So please contact the MHCC team with any technical issues. The meeting's scheduled for 90 minutes, but the meeting agenda may not require the full time today. As a courtesy to others, we ask that you remain on mute when you're not speaking to reduce background noise. Staff may mute you if there's a lot of noise coming from your line. You can mute and unmute yourself using the small button at the bottom of the screen that looks like a microphone. The meeting facilitator will sequence speakers and may also call on people to speak to ensure we have a wide range of perspectives. If you have a question, please raise your hand by clicking the raise hand button under reactions at the bottom of your screen. Another option is to enter your question into the chat box. I'll now turn the meeting over to MHCC Executive Director and Workgroup Chair Ben Steffen to make opening remarks.
Thank you, Melanie, and I want to welcome everyone who's joined us today, the work group members as well as the interested members of the public. I recognize that it's one day before a long Labor Day weekend. We'll try to make your time here well spent, but also efficient, and hopefully we can cover the material and giving ample time for comment within the allotted hour and a half. A couple announcements. I think by now everyone is aware that the state was awarded one of 4 states that was awarded the AHEAD model, the Advancing All-Payer Health Equity Approaches and Development. Quite a mouthful. The state staff has begun to review the participation agreement. That document is not yet public, but lots of work ahead as we work with our partners at CMMI in putting the legal materials together that will guide the development process over the next 16 months and ultimately the implementation period, which begins in January of 2026. Just for reference again, Maryland was one of 4 states, Vermont, Connecticut, as well as Hawaii were also participants. I know that there's a lot of rooting for the model statewide meetings being held in Hawaii, but I think that's unlikely. I would note that Maryland is conveniently located a mere 4 miles from the CMS headquarters, and I suspect the state may be a candidate for some of the convening meetings for the other 3 states as well. That's my hope. As we begin to talk about planning for the AHEAD model, we did convene a all hands on deck meeting of the 3 primary care organizations, work groups that have focused on model development and investment. That was held last week and included the PCIW as well as the MDPCP Advisory Council, as well as a primary care technical advisory committee that was formed to plan for primary care implementation as part of the AHEAD model. We had a presentation from Secretary Scott as well as others in the leadership team at MDH and HSCRC. We also talked about, MHC talked about the various investment alternatives. As you know, PCIW investment methodology relies on the multi-state definition that was developed in consultation with Milbank. Our consultants from Friedman Health also played a leading role in defining that, and we're fortunate that we continue to work with those groups as that definition evolves over time. We also talked about the ahead model definition, which in some ways is somewhat broader in terms of its coverage. Uh, we're not yet ready to determine if all of these definitions can live comfortably, or the state needs to select one. I think there are advantages with both approaches. Simplicity, I would argue for one, but recognition that different payer groups, as they cover different populations, may warrant slightly different definitions. Also has garnered some traction. Uh, we will keep all of this work group advised as we move through the process through the coming months, and look forward to really putting forward the best definition as we work towards full implementation of the ahead model in January of 2026. Uh, so I think there's a lot to do. And P.S., we have been working with our colleagues at Medicaid on their definition of primary care, which could add, yet another definition that we want to consider. I think it's noteworthy to keep in mind that both the ahead model and the uh, PCI, PCIW definitions really focus on a subset of services provided by the affected primary care providers that fall under both of those definitions. Our consultant is working on a really kind of a construct to tell us what percentage of the full scope of services provided by primary care providers that fall into the taxonomies that we are using to define the primary care investment goals, to really guide us as we think about this, because clearly the definition goes to much greater detail than simply saying if you're a family medicine physician, everything you do falls under the primary care definition. And that's true regardless of whether we're talking about ahead or we're talking about the multi-state, or otherwise known as the PCIW definition. That's important to keep in mind as other definitions come forward. We're not merely talking about provider categories. We're talking about provider categories and a swath of services that are deemed essential primary care. With that, I'm going to turn over. I think Melanie is going to give an update on the activities. I think Mary Jo and Melanie are the first to speak. And am I passing the baton to Mary Jo?
I think I'm going first.
Okay. Go ahead, Melanie.
Okay, great. Matt, can you bring up the report slides, please?
But hold on just a moment, Melanie. I think we're getting out of sequence. Mary Jo is going to talk about the up on.
I'm sorry. Sorry, David.
So the update on selected state investment activities, looking broadly across the country. I think Mary Jo was going to present. I think certainly welcome your comments, Melanie, but Mary Jo is first.
Sure. So a few updates to share as we think about what's occurring across the country. So the first is work continues in North Carolina. A initial report was released in North Carolina. That report looked at essentially a path forward for that state for measuring primary care investment and also setting a relative improvement target. Some of the work that continues to go on there is to take data from the payer community and look at some initial estimates of investment in that state. Similarly, in Arkansas, work is occurring there to begin to think about what primary care investment looks like there today and where that may go in the future. So work occurring there as well. A couple of other efforts that have made some significant progress over the past few months in Delaware released new data on the first year of compliance with required levels of primary care investment. compliance was largely achieved. Primary care spending there has increased since that program has gotten started. You might remember that that program really focuses on providers who are participating in value-based payment arrangements known as care transformation activities in that state. Really significant increases in spending for those providers in particular. In California, the state has released a draft primary care investment benchmark of 15%. That spending increase would occur over 10 years. So right now they're around sort of 6 to 8%, depending on how you look at it. The California definition is a little bit broader than some of the definitions out there, in part due to wanting to incorporate some codes that were a focus of some Medicaid activities. So a little bit broader definition there, and in turn, a higher investment target over time than what we see in most states. The folks in Oregon have also been releasing some additional data on primary care investment there. They also had a 2023 investment requirement of 12%. One of the things that I think is interesting about that state is really the dramatic variation that we see across the payers in what primary care investment looks like in that state. And then nationally, some additional work occurring on thinking about what are the lessons learned of from this sort of initial round of primary care investment targets and cost growth benchmark. So exciting work occurring on this across the country. I'll also do a bit of self-promotion. We recently released a report in partnership with the Commonwealth Fund that showed that provider organizations in Massachusetts that had higher primary care investment also had statistically significant better performance on quality measures, significantly lower spending on hospital outpatient and inpatient services, and they did so without increasing or having a higher total cost of care. Ben, was that anything else you're thinking of that you'd like me to mention?
So, in terms of the definition used in California, can you elaborate a little bit more on what was added to reflect the range of services covered under Medicaid?
Absolutely, absolutely. So, Medi-Cal, which is the Medicaid program in California, is currently embarking on an initiative to increase fee-for-service rates for a variety of services that perhaps historically have been viewed as under-resourced, let's say. And as part of that, they came up with a list of codes that they felt that the Medicaid MCOs should increase fee-for-service rates for those services. That list of codes was quite extensive and included a wide range of services and also procedures that had not initially been included in the California definition. So the stakeholders in California who are working on the primary care definition worked with us in the Office of Healthcare Affordability to essentially review those codes that Medi-Cal was proposing higher fee-for-service reimbursement rates for, to see which ones should come over and also be sort of included in the primary care investment definition. So examples of those, as I mentioned, were some procedures, some additional behavioral health and OBGYN services, et cetera. And then there were also some that the work group said, those just aren't primary care. So for example, air ambulance was one of them, and other types of emergency services, ED visits. So that was part of the work group's work in that state, and the result of that was a broader definition than what we see in other states.
Thank you. David, did you have your hand up?
I did not then.
Are there questions for Mary Jo from the work group. Okay,
I do have a question, Ben,
go
for
ahead,
Mary Jo.
Dr.
I think the issue we always run into with the feds in particular is that Maryland has the Maryland model. And I know that the MDPCP has been looked upon quite favorably, except for the fact that there haven't been significant savings so far. So how does how should our approach be, considering the background of California, who have already put this forward? Should there be a significant difference because we're Maryland model, or should there be similarities?
Well, I think I first want to signal that there has been some recent evaluation results that have been a bit more favorable for the MDPCP model. And I'm going to call on Chad to, maybe briefly mention what the Hilltop study found, which I think it's safe to say did not fully align with the evaluation results that had been released by Mathematica over the last couple of years. Chad, can you speak on that, or is that something that we should hunt to a follow-up communication?
Yeah, I probably can't speak to the details yet because it's still going through the approval process because it has to be included in the joint chairman's report back to the legislature for October 1st. But we are going to give CMMI a heads up on what the findings are, and the findings are pretty favorable on both utilization and savings, and suggests that the program actually is providing savings over and above the cost of the program.
Thanks. Thanks, Chad. So, Dr. Khanna, that's the latest breaking. Stay tuned for
That is awesome. Good.
In terms of, I think the MDPCP will be, it's dangerous to speculate exactly how it's going to evolve under a head. But my understanding from what Mary Jo mentioned about California, I think that definition is in development, under consideration. I'm not sure if that has been agreed to, but I'll yield back to Mary Jo if you can add a little clarity for Dr. Khanna.
Sure, absolutely. So I would say the definition is close to initially final. So I don't know that that's quite the it's like the clarity of mud, but the definition has gone through an extensive work group process. It is in it's the ink is drying on the pen that has that definition. There's still maybe 5 or 6 codes that are being discussed. But we are super close. The definition does not have to be approved by the board. And so, but will be presented to the board at its September meeting, which is basically the endish of September.
And would California be looking at a single definition, or would different definitions be created?
So, yes, California is looking at a single definition that will likely include a behavioral health module. So they're also measuring behavioral health spend. So to be able to isolate primary care spending related to behavioral health services, there'll be a module that can be sort of added to either one of those spendings and then subtracted when they're both used.
Thank you. Okay, seeing no further questions, I think it is now Melanie's turn to talk about she's going to do the introduction, I think, for the next segment. Is that right, Melanie?
Yes, we're going to start talking through the 2024 report.
Okay, go ahead.
Please bring up, thank you, Ben. Thank you. Please bring up the slides for the 2024 report.
And if you could, Mac, if you could go into Slide presentation mode is probably would be better for visibility. So if you click on slideshow and then from the beginning, I think that'd be good. Move your cursor to slideshow and then click on that. And then that should bring up the options, and you want to start from the beginning.
Okay, this is the beginning, correct?
This is the beginning, correct. And if you click on the slideshow, it's going to open up the screen and we have a bigger window. It makes it more visible. The panel on the left will disappear then. So move your cursor to slideshow, click on that. Yeah, you're able to move your cursor to slideshow.
Okay, I see it.
Here, I got it. That's the other slide there.
Melanie, if you think it would be easier for you to present as the presenter, then that might be helpful at this stage.
You guys see it?
Yeah.
We can see it.
Okay. Can everybody still see it okay?
Yes.
That's good.
Okay.
If you X out panels on the right, viewers, that'd be.
Is that better? Or?
It was fine before. So.
Oh, okay. Okay. Okay, guys. As a reminder, in 2022, the Maryland General Assembly passed legislation that established the Maryland Healthcare Commission primary care report and work group. This legislation requires MHCC to conduct an annual analysis of primary care and offer recommendations on the level of primary care investment relative to overall health spending. So the 2024 Primary Care Investment Analysis and Recommendations Report marks the first comprehensive analysis of primary care investment over the preceding year. The report provides an update on progress in increasing investments in primary care and offers recommendations designed to help address the urgent challenges within primary care. So nationally, about 20 states have either enacted primary care investment initiatives or have them pending. You heard Mary Jo talking about that earlier. The states with the longest standing primary care investment targets are Colorado, Connecticut, Delaware, Oregon, and Rhode Island. Colorado established a set of annual priorities for primary care providers and payers to guide investment in care delivery. Delaware focuses on providers engaging in care transformation activities. Oregon initiatives highlight the benefits of coordinating across primary care and behavioral health, as well as efforts to address patients' social needs. Rhode Island has a long-standing medical home program that offers additional primary care payments. More recently, several states, including Maryland, Nebraska, New Mexico, North Carolina, and Oklahoma, established recommendations or targets for primary care investments. They're in the process of identifying strategies to achieve these goals. So earlier this year, the commercial payers were asked to complete a value-based care environmental scan. The payers collectively reported 47 APM contracts. 12 were shared savings programs with downside risk covering over 100,000 members. So Aetna reported 10 contracts, CareFirst 18, Cigna 19, and 11 of those are part of their ACO model. So the payers really focus their efforts to increase primary care investment largely through these value-based care models. And they were primarily implemented within large health systems, often through ACO structures that emphasize population health strategies. So now I'm going to turn it over to Mary Jo to talk through the key findings of the report.
So before Mary Jo begins, just a note that we'll hold questions till we get to the end of the presentation, and then people can ask both Melanie and Mary Jo questions. Go ahead, Mary Jo.
All right. Thank you so much, Ben and Melanie. So first, big thanks and to Ken Yates-Trotman and the data team at MHCC for conducting the analysis. I think we're about to show you some really interesting findings. If we go to the next slide, before we dive into the results, I just wanted to share some background on the analysis and also a few caveats as well. So the data comes from MHCC's all-payer claims database. So what we have included at this time are fee-for-service payments for primary care services. We'll talk more about measuring non-fee-for-service spending later. What we're going to be looking at today is 3 years of data, so from 2020 to 2023. And this includes data from commercial payers, Medicare Advantage, as well as Medicare fee-for-service. Now, just a note that the 2023 data includes 9 months of claims and 3 months of runout. And also that the Medicare fee-for-service data only goes through 2022. It takes them a little bit longer to get their data into the APCD. Another note on those Medicare Advantage plans, all of the Medicare Advantage plans are included here except for Johns Hopkins and Alderwood Advantage. So Alderwood is a relatively new payer to the APCD. They've since begun submitting data to the APCD. They were just not submitting data at the time of this analysis. I'm particularly excited to show you some really interesting geographic analyses that the MHCC team pulled together. And you'll note that in the appendix, you will also find analyses by race, as well as the percent of members with Medicaid by zip code. So just to sort of talk about how that's calculated, it's the percent of members with Medicaid by zip code. This includes all Medicaid enrollees. It's then divided by the total population, so including commercial, Medicare Advantage, Medicare fee-for-service, and Medicaid in a given zip code. All right, let's go ahead and go to the next slide. There we go. We're already there. And I will talk a little bit about the key findings. So MHCC looked at spending data as a per member per month amount. So taking the total amount of spending using the PCIW definition of providers, services, places of service, and dividing by the total member months, as well as on a percent of spend basis. So essentially taking that total primary care spending and looking at what is the proportion of the total healthcare dollar that was spent on primary care. And, you know, it's important to look at this information both ways because each metric is really telling us a little bit something different. If we go ahead and review some of this data here, you'll see that spending ranged from an average of 3% of total medical expense for Medicare fee-for-service members to 6.1% of total medical expense for commercial members. As I'll talk about more in a few minutes, this is really consistent with what we see in other states where Medicare spending as a percent of total spending is lower than commercial. And that's largely because Medicare fee-for-service members have higher total spending than commercial members. One thing that was interesting here was that commercial payers had generally consistent spending. We'll talk more about that in a minute. It's about $20 per member per month. And also that spending has declined a bit on a per member per month basis. So we'll talk more about that in a minute as well. And then I mentioned that there was some interesting variation occurring across the Maryland counties. So about 4% of total spending occurring on primary care in Allegheny County, to 7.1% in Calvert, Frederick, St. Mary's, and Wicomico. And you all can make fun of how okay, I was just going to say, you all can make fun of how I just pronounced that one. All right, so let's go ahead to the next slide. And, you know, we thought this was pretty interesting. So if you see here, the commercial spending in particular is quite flat on a percent of spend basis. What was interesting also was that on a per member per month basis, we actually saw it decline a bit. So this was interesting because in most other states, we see steeper increases in total spending. And when that occurs, the PMPMs for primary care might actually go up, but not as a percent of spending, because that denominator is essentially growing too quickly for the primary care spend to go up. We did not see that here. Here we saw the percent of spend staying mostly flat for commercial and Medicare Advantage, and then going up just a bit for Medicare fee-for-service. But what we're going to show you as well, though, is that in Maryland, we actually saw the PMs go down a bit. So for commercial, per member per month primary care spending was $24 in 2021. Now it's around $19 for Medicare Advantage, going from $41 to $32. So while that percent of spend was flat, the per member per month amount was going down a bit. On the Medicare fee-for-service side, it went up a bit, both on a percent of spend basis and also on a per member per month basis, increasing from about $23 per member per month to $28 per member per month. Again, only 2 years of data showed there, though, because the Medicare data comes in a little bit later than the others. So we only had 2 years to include here. If we go to the next slide, I want to highlight here the percentage differences that are shown are driven both by differences in spending on primary care on a per member per month basis, as well as differences in total spending. I referenced this briefly on the previous slide. And as I mentioned, this is typical with what we see in other states, where per member per month amounts for primary care are higher for Medicare than commercial, but the percent of spending is lower. And that's because older adults with Medicare tend to have higher total spending than the commercial population. All right, this next slide was also very interesting, where we saw if we could go back one, I think, yep, right there, thank you. So you'll see that most of the commercial payers had almost identical spending on a per member per month basis. So between $17 and $20, that's sort of where all that cluster of dots sits there. There was one exception on a percent basis, and that's over there closer to the 7.5. You'll note, though, that that payer also had spending on a per member per month basis very consistent with the others. And so that difference in percent spend was really driven by a lower total spend, not by what was spent on primary care. For those of us who look at primary care investment spend numbers a lot, which I tend to as part of my job, this was really interesting because we don't typically see payers so close to each other in the dollars that they're spending on primary care. So that was particularly interesting to me. I will again note that this is based only on fee-for-service payments. And so if there were non-fee-for-service payments made toward primary care, it would not be shown here. All right, now let's go to that map. So here you see some of that difference in spending across the state of Maryland. And here it's shown using a map format, which can be interesting. However, if we go to the next couple of slides, we'll show it using a table format. So here using a table format for commercial, and you'll see that for commercial, it's pretty consistent across regions, both on a per member per month and on a percent of spend basis. Now, if we go to the next slide, it's a bit of a different story for Medicare Advantage, where you'll see that spending ranged from $30 PMPM and about 3.2% of spend in the Baltimore metro area, all the way to $44 per member per month and about 4.1% of spend for Western Maryland. You'll see that DC Metro had a similarly high percent of spend as Western Maryland on the Medicare Advantage side, but the per member per month was actually closer to Baltimore Metro. And that kind of shows you how higher per member per month spending doesn't necessarily mean higher percent spend, because what can drive that percent spend is also what's in the denominator, what was spent in total on healthcare services. One of the things I want to note is that the regions that you see on this slide in the next group Eastern and Southern Maryland together. That's because some of the data in terms of the groupings and some of the other factors, this was made to look more similar to the MIA categories. I'll just kind of leave it there. The Maryland Insurance Administration categories. All right, let's go to the next one. And you'll see here the Medicare fee-for-service primary care spend. Similar to commercial, this was really consistent, largely consistent across the regions, ranging from about 2.8% to about 3.3% of total spend. Baltimore Metro and Eastern Southern Maryland coming in at $27, and then DC Metro a little bit higher at $32. All right, so now that we've shown you some of that data, we wanted to provide you with some recommendations that will be coming out of the report. So if we go to the next slide, just want to say I think these recommendations set a really important strategic foundation for Maryland as it moves forward. I think they're detailed enough to provide the state with the direction on next steps that's necessary to advance this forward. And yet I also think that they are broad enough that they can adapt and evolve as Maryland continues to pursue the AHEAD model. The recommendations were developed with the input of many stakeholders. They also reflect the data that was collected as part of the report development. And I think that they also, as I mentioned, sort of allow Maryland to move forward with this work as well as with the AHEAD work as it sort of pursues both of these initiatives. So the first one is to require payers to annually report detailed information on primary care investments via the alternative payment model data submission. So as you may be aware, about a year ago, MHCC began collecting information on alternative payment models and spending related to alternative payment models. That provides a vehicle for MHCC to collect information on primary care investments, including those that are made outside of fee-for-service payments. And those submissions and the amount of spending then can be used to assess the impact on health equity, quality, and cost that are resulting from increased investments in primary care. This reporting, as well as supplemental data that could come from the APCD and other data sources, enables the utilization of a comprehensive reporting structure to assess primary care investments in dollars and as a percentage of spend. And as I mentioned before, bringing into account both claims and non-claims data. We also appreciate that there's a need to strategize and how data is used to measure the effectiveness of increased investment on quality. So many of you during some of our previous sessions have weighed in on what some of those measures could be. Another component of this would be to establish data use guidelines to supplement payers' internal analyses to support all payers in developing effective investment strategies. Right, there's one more if we go to the next slide. The last is to enact legislation that requires payers to increase investment in primary care as a percentage of total medical spending to meet minimum thresholds in line with the recommendations of the 2024 Primary Care Investment Analysis and Recommendations Report. And that investments will be aimed at primary care providers who participate in value-based care initiatives or have achieved recognition from NCQA primary care medical home participation. We also want to note that ahead, the Advancing All-Payer Health Equity Approaches and Development model will require Maryland to meet primary care investment targets for Medicare, Medicaid, and the commercial market. So this helps achieve that goal as well. And therefore, setting targets in Maryland law is appropriate given those ahead model requirements. So as I mentioned, these recommendations have been developed based on the data that we've received. They've been developed with the input of many stakeholders and really allow the state to have a vision for next steps in advancing primary care investment while also aligning with the work of AHEAD and other initiatives that are currently in place and in development in Maryland. We welcome your questions today. I will say if you have comments on the report recommendations, take some time to think those through. I would encourage you to share any comments or feedback on the recommendations themselves with David or Melanie by email, over the next few days. And they can review those comments as they come in. All right. So let me talk through a few next steps. The first is to continue to support payers in identifying methods to increase investment in primary care and also assess whether or not care delivery is improving as a result of those investments. So essentially, are we getting value for the additional money being spent? This effort will involve bringing together primary care investment measurement and aligning the payers' primary care models with the AHEAD model. We also look forward to engaging stakeholders in discussions around how we refine the primary care investment goals, and in particular, think through how funds should be allocated across primary care providers. And then the last step here, really continue to explore the most effective approach for recognizing non-claims payments that are working to enhance primary care services. This can be complex. We've worked on it in several states. It looks a little bit different in each state, but important to think about how we understand those payments and include them in primary care measurement over time. All right, with that, I will open it up to your questions.
Thank you, Mary Jo. Let me turn back on my camera. And I'll ask a question as other people begin to frame theirs. A little disappointing compared to where we were last year, it doesn't seem there's like, especially in the commercial market or the Medicare Advantage plans, we see much progress. Do you want to react to that?
Sure. And I would encourage stakeholders to share a little bit about what they're seeing on the ground as well. But that's true. When we look at primary care spending on a fee-for-service basis and we look at those per member per month amounts, we're not seeing an increase. We're actually seeing a decrease. And, you know, I think it will be interesting to hear from others about, you know, how that is playing out for primary care providers across the state.
I also had one question about Medicare Advantage. In Maryland, Medicare Advantage has historically had low uptake. That is changing. In the last couple of years, we've seen 10 to 15% growth in Medicare Advantage enrollment in Maryland. We're still far below the Medicare Advantage penetration rate nationally, which is now for 2024 is about 50% of the beneficiaries for 2024. I know we don't have data, but in Maryland, that was about 25%, still almost 250,000 beneficiaries. But what do you think in terms of Medicare Advantage? That went down, but it's kind of hard to unpack, you know, what the implications were of it. It was fairly significant surge in enrollment from 22 to 23, and we'll see that again in 24. Any thoughts on how increased enrollment in that product might be shaping the spend? I don't know is also an acceptable answer, by the way.
I'll start with I don't know. One guess might be that as folks come into Medicare Advantage, they will hopefully be connecting themselves with a regular source of care. And that will increase primary care spend as they have that regular source of care. Perhaps they, you know, haven't taken the time to do that as they've been working and busy with other things. But as they come into Medicare, hopefully they choose to do that. It looks like Chad has his hand up, Ben, just also.
Okay, Chad, go ahead.
I don't have a thought on that one either. I don't know. So I'll let you finish first, Mary Jo.
Thought you were going to save me on that one, Chad. No, I don't know. The only thing I could think of is that might have an influence. But to be honest, I think it's unlikely to be related.
Chad, did you have another comment?
I did. I had a separate question if you want me, if this is the time for it.
Yes, go ahead.
So, hey, Mary Jo, great work. Really good report and analysis. I was curious, and apologies if I missed why you think this might be, but the Medicare fee-for-service numbers look particularly low and much lower than estimates that I've seen, and certainly lower than estimates I've heard from our federal counterparts. And I know they're talking about using a different definition than we might use, but given how low it is, it does concern me that we're going to be measuring almost something different. And I wonder if that's because of data completeness and what maybe we're missing, the data definition, or what you think might be driving that.
Sure. So one thing I'll note is that, the group also, MHCC also looked at spending using the AHEAD model definition. And using that definition, spending was generally about 2% higher than it was under the PCIW definition. So that, that's not insignificant, right? So if we think about, I have the slides up on my end just so I could sort of work off of my talking points here. But, so on the Medicare fee-for-service side, that would increase it from 3% to maybe 4 something. And that's a pretty big jump when you think about it on sort of a percentage basis.
Yeah, I mean, I think I would observe that if we factored in AHEAD, that definition as opposed to the multi-state definition, we would start to be getting into the estimates that the federal government, the CMS, has reported in their various ahead announcement documents. I think we're much closer. Agree, it's a bit lower. Are you able to, in terms of the MD-PCP population, give us a Medicare share of, I mean, a primary care share of spend for that subset?
I think the latest we looked at was 2023, and we've used Graham Center definitions for that. So it's probably similar, but not exactly the same either. But I think the numbers we came up with were closer to 7 or 8%.
Yeah, that I would think. And did that include non-claim based primary care payments?
That did.
And that's one thing to keep in mind. I think that Mary Jo brought out at the start of the presentation that this is straight up old, the claim data, and it doesn't capture any of the value-based payments. Pretty minimal in the commercial sector, but more significant certainly in Medicare. And I'll let my Medicaid colleagues comment on the magnitude of non-claim based payments for Medicaid if they want to, but I think that's a important consideration.
Then we have 2 questions in the chat. So if it meets with your approval, I'll tee them up for you.
Sure.
The first question, good afternoon, Sally Ann. It is, to what degree would the inclusion of Medicaid primary care spend impact both spend and percent?
And I'd add to that, David, given the size of our Medicaid population and its focus on primary care.
And Mary Jo, would you wish to able to take that for us?
I would probably defer to our Medicaid colleagues who are on the phone or participating in the meeting. Have not seen estimates of Medicaid primary care spending in the state, and so wouldn't want to speculate on that.
If Laura or someone else.
Yeah, hi. I can jump in, and thank you for the question. And I think Trisha's on as well if she has additional commentary to add. We've started taking a look using both the this work group's definition as well as a version of it that has adaptations. I think what we're seeing so far is primary care spending looks pretty good for the MCOs, but I think there's a lot of differences between. I think we need to shake out the denominator before we can really see how this will affect, our primary care investment targets, for example. Medicaid, what we've measured so far is percent of primary care spending by the MCO over the MCO total. And of course, we have several large benefits that are carved out, including dental and behavioral health, long-term services, and supports. And there's just inherent differences between the Medicaid benefit package. We do cover more. So, inherently our denominator could be larger depending on how we determine to measure that. So our, meaning that our primary care spend could be artificially deflated if we're comparing against other payers or, kind of including with a all payer measurement. So those are the things that we're continuing to ponder and happy to take any feedback on that or thoughts or ideas.
And Trisha, did you have anything you were going to add?
No, Laura gave a really nice answer of where we are with kind of collecting the information. What I will say in Medicaid, where we have been targeting rate increases, right? We've been targeting E&M rates for physicians, up until just recently. We've been paying, last year we were paying about 103% of Medicare. So, in general, right, if you're looking at where the higher rates are, primary care is probably billing more of those. And so we look better. We're not as high on other codes and other specialties. So obviously that's going to bring the primary care investment target up in Medicaid, just simply because that's where we've been investing in terms of paying higher rates.
Okay, thank you.
I think Dr. Bernstein had a question.
Yes, sir. Dr. Bernstein.
It's really a very closely related question to Sally Ann's, just in terms of the data for the commercial. Does that include, age ranges outside of Medicare? I mean, when we look at the Medicare fee-for-service and Medicare Advantage, but it's really a lead into just what we've been talking about. As we expand our definitions and alignment to include Medicaid and commercial, and expand the definitions for younger age groups and broader primary care, how will that shift the data? So it's closely related.
Sure. Oh, go ahead, Ben.
Go ahead.
Yes, and I think, when you look at the proportion of total spending spent on primary care, those age differences really pop out, right? Because essentially you see higher per member per month amounts for primary care spending in the Medicare population, but lower percent of spend. And that lower percent of spend is really driven by a higher denominator, right? So, Medicare beneficiaries just tend to cost more when it comes to healthcare than, 30-year-old commercially insured enrollees. That's just sort of the nature of things. And so the percentage is naturally going to be lower when we have a Medicare population than a commercial population.
Yeah, and kind of wanted to emphasize, Dr. Bernstein, that the second generation PC primary care definitions are evolved from first generation definitions, where you basically looked at specialty or taxonomy codes only. So if you were a family medicine doctor, everything you provided was deemed primary care. The second generation definitions use a combination of codes and either taxonomy codes in the case of the multi-state definition, or specialty codes in the case of a head model, so that I keep pushing Mary Jo to do this little study for us. Not all services provided by the typical family medicine physician are going to fall under the primary care multi-state definition. If we wanted to grow the level, we could just say, if you're a primary care physician, family medicine, everything you provide is primary care. By that broadened definition, the percent that's primary care would automatically grow. But the second generation definitions are trying to be more granular and specific, and dropping some things out of the definition. What I want to try to do is look at what percentage is our defined primary care services as a percentage of all services provided by the key primary care specialties, or the key primary care taxonomy codes. And I think you can argue that first generation, which is kind of like a PCMH type definition, everything provided in a medical home is by definition primary care. But I don't think that's the way most states are going right now, and they're trying to be much more specific in terms of that definition. But I think the old "let 1,000 flowers bloom" is probably going to exist here for some time before we finally hone in on a definition that everyone can agree on.
And then Nora Hoban has a question.
Go ahead, Nora.
Oh, hi. Thanks, everybody. Yeah, I don't know where this fits into this conversation, but we've had 3 of our community health centers work with an organization called ConfirmEd. And what they do is, it's under a whole grant for health equity that an arm of Quest has provided for us. So We're not paying for it right now, but what it does do is it allows our providers, when we have a potential specialty referral, it allows them to get a consult by, it could be a dermatologist, it could be a cardiologist, and if that primary care provider can just handle it with a little bit more information from a specialist, it stops that referral. It stops that increase in a specialist visit. It also helps reduce costs by not ordering extra tests. If that primary care physician, gets concerned and starts ordering more tests, you're in consult with a specialist that can prevent that from happening. So we think it has great promise, but it's about to be up at the end of October. And, what I feel a little bit bad about is we're talking about primary care, and we've spent all this time on the definition of primary care, and this has a specialist connection. But I do think it's an innovation, and it's also an innovation that leverages our silver tsunami that we have going on here with the lack of providers, both primary care and specialists. So I just wanted to offer that up. We are getting data from the company to learn about the number of referrals, the type of referrals, and I do have some other qualitative data reports and studies about it that I would like to see us kind of figure out where the play is here.
That's a good suggestion. Nora, we're going to follow up with you.
And Ben, there's a last comment from Shule. However, I would suggest that her question will be answered by Kenneth Yates Trotman during his presentation. That perhaps I could ask her to hold on, and if he doesn't answer it, we could come back to you, which I think he will actually.
Yeah, I think that it's not going to exactly answer it, but I think Kenneth, if you go ahead, and then we can circle back to Shule at the conclusion of Ken's presentation.
Right, Shule, we haven't did any adjustments, from a risk adjustment basis or age adjustment, for this study as yet. So we haven't done that as yet, but this is something that we probably could actually do in the future.
Go ahead. If you want to start your presentation on the additional data that we have, that'd be great. I think Melanie who's running the slides.
So if you can bring them up, that would be helpful.
Yeah, I'm bringing them up.
Okay, thanks.
Can you guys see them?
All right, yes, thanks. Next slide, please. So what we want to do, we want to give an overview of the data that was used to first query the data, and also look at a deeper dive of the results from these codes. So as far as codes are concerned, we consider that the primary care taxonomy codes that we use for the primary care specialists, and which were like 39 codes. And then for the core set of CPTs, for primary care, it was about 97 codes. And then for the behavioral health, those are services that were rendered by a primary care physician, that was a 161 codes. And then for the behavioral health taxonomy codes of specialists, which have to be integrated with a primary care practice, but billed by a primary care physician to be a primary care, those were 22 taxonomy codes. On the OBGYN services, which have to be rendered by a primary care physician, those were 86 codes. Then we have the place of service codes, which we did not use. We used earlier on in the study, but we didn't really focus on the place of service codes. Next slide, please. So onto the results at a deeper dive. And So for commercial primary care spend, we look at this drill down by county and by private payer. All 24 counties. We look at the percent spend, and also by year, and also by region. We also look at the associated primary care PMPM spending by these breaks as well. Also, we kind of like look at from a more aggregate standpoint, meaning that we look at the primary care spend by county, but with all of the private payers combined, and also by year. So with that, we found there to be less volatility as the 24 counties by payer were more granular, but this one were more rolled up, so it gave more stability to the results. On the Medicare fee for service, had the same breakout, but this is only one payer, as opposed to the payers that make up the primary care, the commercial data. Also, the Medicare Advantage, which is similar to the commercial data, it has primary care, the private payers as well, similar to what we have on the commercial side, but it's the same breakout, same deep dive by county and by payer and by year from 2021 through 2023. Moving down to the commercial primary care, we look at this spend by age categories. And first, we look at 3 age groups from less than 30 and between 30 and 64 and greater than or equal to age 65. And also look at this by year from 2021 to 2023. We also look at spending by race and ethnicity, and also by gender. We also had another breakdown of age. We look at age under 65 in total and age greater than or equal to 65 years old. And then for the Medicare Advantage and the Medicare fee for service by age, gender, and ethnicity, they were the same breakouts. Next slide, please. That's it.
So those tables, where will those tables appear, Ken?
Those tables will appear as a separate document, as a supporting document on the website. Is that correct, David?
Yeah, so they'll be released. These tables are compiled in a broader set of data, and we're releasing it as a data supplement. So there'll be a report on the recommendations, and then there'll be a second report, if you will. It will be the data supplement that everyone can look through.
And when will we be able to share that with the work group?
We'd like to send it out. Our hope is to send out the drafts, both after the Labor Day holiday.
Okay. And so I think we should circle back to Shulei's question. I think that certainly presenting tables by different demographic categories doesn't quite qualify for risk adjustment, but we are starting to drill into variations in primary care spending by race, ethnicity, age, and geography. And Shulei, if you could wait a few days, we'll make sure you get a copy of those tables. Clearly not up to the standards of what Mathematica would characterize as risk adjustment, but certainly gives you some ideas on perhaps the evolution of a risk adjustment tool that could take that into account as we move forward in our understanding of primary care spending. Do you have any follow-on?
Thanks, Ben. No, it's not urgent. So I think kind of reflecting on Dr. Bernstein's commercial.
Okay, absolutely. I look forward to sharing that with you. Any other questions? I know Ken's kind of just gave you a teaspoon of what you can expect in those tables, but look forward to sharing them with everyone in about a week. David, I think we're going to meet our mark of getting done in an hour and a half. You want to go ahead and talk about the activities over the next 6 months? I know we talked about sharing this, but why don't you go ahead?
Sure. Again, good afternoon, everyone, and thanks for participating. Just in a nutshell, the first matter of business is to get a date on the calendar for the primary care investment work group, which of course is open to the public, to convene in the early fall. So keep an eye on your calendars as we send out some notification dates and see how that works for everyone. Areas of focus will be further looking at the definition of primary care investments. We heard Ms. Goodman and Ms. Roddy talk a little bit about the great work that Medicaid is doing looking at the MCOs. We know that CMMI has a definition that's used, that they're using in their particular program, as well as the PCIW. There's overlap, but there's differences. So we imagine there'll be opportunities for the work group to talk further about that as we get into the early fall. Next up, we'll probably start beginning to talk about how quality is assessed, how we measure quality in this type of program. We heard that come out a little bit in the recommendations or findings from the report. And we'll begin to work with payers, talk about how we can help payers begin to monitor the investments and what strategies should be considered to do that. So it'll be thinking about the recommendations and how we can advance them that we heard presented earlier on in this meeting. So with that, I would say stay tuned. We will have the 2 reports in draft form out next week. For those in the public, it will also be posted on our website. So I will turn this back to our executive director.
Thank you, David. I think a key question is the point that Mary Jo raised at the start of her presentation, that primary care spend has not really changed that much yet. We're only a year into actually measuring it, but it does raise some questions, especially as we think about what we know will be much more compelling requirements under the AHEAD model of what we can do to spur primary care spending. Certainly we're missing small things right now in the commercial space because we don't capture non-claim based payments. But we think that's very marginal at this point as CareFirst and others evolve their primary care models where non-claim based payments are going to play a bigger role that could change. So I think there are really two steps that we really need to think about, and that is, what efforts or how should we direct our efforts to encourage commercial payers in particular to elevate the importance of increasing primary care spending, and to fully give them full credit for their those investments. What steps do we need to take to capture non-claim based payments? It's notable that we do already collect some non-claim based payments. We're like this only 1 year into that effort, but that may provide a platform for broadening what we collect, because non-claim based primary care payments are just around the corner in my judgment. But we do have some major policy decisions to think about, even as the major challenge, which is planning for the implementation of AHEAD, is our primary priority over the next 18 months. So lots of things to think about. I think we're listening to all the ideas on primary care definitions. I think there are advantages for each of the proposals that we've heard. I'm somewhat agnostic. I think there is value in agreeing on a consistent measure across all populations, but we want to be sure we understand the challenges with doing something like that before we rush full steam ahead on one definition. I think, what I would say is that the second generation definitions are much more granular in that they're not just capturing PCMH programs, or medical home programs. They're really drilling down into the services that different primary care specialties are actually providing. My guess is that those definitions, if we looked at the typical primary care physician, perhaps 60 to 70% of the services actually fall within the primary care definition. But we'll wait till we have some definitive data on that before we put a stake in the ground on what that actually means. But I think we're moving into more sophisticated measures, and we welcome everyone's ideas even as we move forward with our recommendations. So Melanie, any last points that you want to bring to the attention of the group before we adjourn?
Just a couple of high-level administrative items. The meeting materials from this meeting, they were included in your reminder email. They're on the PCIW Workgroup page. So those are the 2 slide decks that you saw on the agenda. That's the same place that we'll post the recording for this meeting and meeting summary as well. If anybody has questions on the meeting materials, please feel free to reach out to me.
And I think David mentioned, we are thinking of another work group meeting later in October. It's still tentative. We're not ready to announce the date, but I think in terms of progress that we've made, we'll be ready to share some additional information with this work group. We expect that the hybrid work group combining all 3 will possibly also meet again. But we again don't have final dates on that either. I'd ask everyone, please pay attention to your emails as the fall progresses, as more information will be shared with you. The first thing you can look forward to is the draft of the report. We again expect to send that out to you shortly after the Labor Day holiday. As I conclude, I want to thank all of you for your persistence in sitting through a meeting one day before the Labor Day holiday. I want to thank our consultant, Mary Jo Condon, and especially thank all of the MHCC team for working to put this meeting together and preparing the information that was presented here, in addition to everything else they're doing. So thank you to all of our team for the work you've done. And with that, I think we're ready to adjourn if there are no further comments. Thank you very much. You all have a great Labor Day.
Thank you. Have a good weekend.
Yes. Bye now. Thank you. See you later, Sally Ann. Bye now.
Bye.